All right, just about to get going with the next session here. Welcome to all of you to the Neuroblastoma Parent Global Symposium 2020. My name is Helen, and I'll be moderating this session, which is on the topic of bivalent vaccine studies. I'll be delivered today by Dr. Shakeel Modak, who is the attending pediatric oncologist and the acting chief of the Neuroblastoma service at Memorial Sloan Kettering Cancer Center in New York. So before we get going, I just want to orient you guys to the bottom of the screen where there's a Q&A button. As you listen to the presentation, if some of your questions are not being answered, you can click on that and ask your question, and right at the end of the presentation, we'll go through some of those questions and see if we can get those answered. If the Q&A button is not popping up for you, then if you scroll kind of over with your cursor or tap on it, it should bring that up for you. And if you see a question there in the Q&A that you like, that is similar to your question, then if you tap it and give it a thumbs up, it does move that question higher in the queue. And the question then we know is one that several people are interested in hearing about at the end. So I think that's it. So over to you, Dr. Modak.
Great, thank you so much. And I'm really happy to be here, even though this is far from optimal. But in a way, I'm glad that perhaps more people can join in. And I'm happy to take questions about the topic of the vaccine. And I leave that towards the end. And let's hope this QA format works, but I also told Helen that if there are other questions, I can be reached by email at the end. So I do want to thank Solving Kids Cancer and above all parents and families to allow me to share some of the information about the vaccine trial that's going on. And these are my disclosures. I wanted to talk today about what is a cancer vaccine, what are the challenges on making a vaccine against neuroblastoma and cancers in general, and then to share some of the data from the phase 1 and phase 2 study, part of which has been completed. Where does the vaccine fit in the current treatment for neuroblastoma at Memorial, and something about our future plans. So this is a slide from Dr. Chung's paper, like a review on neuroblastoma. And what this shows is that if you look at the center and the neuroblastoma cell, that can be attacked by many types of immunotherapy. And over the years, we've been able to harness various parts of the immune system to make this happen. So we all know that antibodies, which are shown here in blue, these antibodies stick to GD2, which is a molecule on neuroblastoma, there is a lot of GD2 on neuroblastoma cells. And then one part of the antibody then attracts white cells to come in and then kill this neuroblastoma cell. It also deposits what's called complement, which also kills neuroblastoma cells, and it also attracts NK cells, which also have the capacity to kill this cell, which is recognized by antibodies. So that's how the current antibodies work, which is dinutuximab or 3F8 or dinutuximab beta. Many of the parents and children who are on this call have received these antibodies. But the problem with these antibodies is that they are short-lasting. They only last while they're in the system, but once they're out of the system, out of the body, they don't work. That is, there's no long-term effect of antibody therapy. So the question is, can we create long-term immunity against neuroblastoma? And one way to do that is to make cancer vaccines. And these vaccines, which I'm going to talk about a little bit, basically work through dendritic cells and other similar cells to create a long-term immunity in the body. And really, that's the goal of cancer vaccine therapy. So what is a cancer vaccine? Cancer vaccine is any therapy that leads to an immune response against cancer. So it doesn't actually work itself, but it stimulates the body so that an immune response can be obtained. And that immune response should be exclusively against cancer cells, because the immune response against normal cells, we are going to get a lot of toxicity. So the cancer vaccine has to direct or be able to direct this response against a cancer cell. And then there are two types of responses cancer vaccines can make. One is they can make antibodies within the body itself. So imagine a vaccine stimulating the production of endogenous 3F8 or dinutuximab. So these antibodies, we know that the vaccine, and I'm going to go into that a bit later, the vaccine can actually create this type of antibody within the body. And these antibodies can then be measured in the blood. And when we measure these antibodies in the blood, they're called titers, as some of you might have heard. Another way a vaccine can lead to immunity is by harnessing or creating T cells that can attack neuroblastoma. And both of these responses are connected. In order for a vaccine to make antibodies, they first have to stimulate T cells, and then the T cells help B cells to make these antibodies. Now, as opposed to as I mentioned, immunotherapy with antibodies, the vaccine therapies is called active immunity, or this immunity can be long-lasting, and that's the goal really, to make this type of immunity long-lasting. So that's a little bit about how cancer vaccines work. But cancer vaccines are not really part of the mainstream of therapy for cancer, and that's for various reasons. In fact, if you look at all the immunotherapies that are approved for all cancers, there are only 2 FDA-approved cancer vaccines, and there are many more than 30 antibodies, for example, that have been approved. And one of these cancer vaccines was kind of created a couple of decades ago, and that's not really being widely used. It's the vaccine against prostate cancer. And the other vaccine, which is against melanoma, uses a virus that is injected directly into the melanoma. So really this field is still not seen its potential completely being realized yet. And there are many challenges, many reasons as to why. One is we've got to find the right target for the vaccine, and this target is often called the antigen. And when the body makes a vaccine, elicits an immune response, it has to only target the antigen and not normal tissue. So that's another challenge. Then the question is clinically, when should we use it? Should we use it at a time when there is very little disease or when there's a large amount of disease? And one of the problems with existing vaccine trials is that doctors and scientists and immunotherapists want to tackle very major problems, such as, for example, brain tumors, where there's a large amount of disease. And sometimes vaccines are introduced as possible therapies for this large amount of disease, a high burden disease. And in my view, at least, vaccines are not designed to take care of large burden disease. And that's one of the reasons why many vaccine trials have also failed. Then another challenge is that in children, stimulating an immune response is difficult. One is because many of the antigens that are there are also present on normal tissues. And many children with neuroblastoma have had a lot of chemotherapy, and their own immune cells are not receptive to making an immune response. So these are all reasons why cancer vaccines haven't really entered the mainstream of cancer therapy, but that's not to say that the future, there's a lot of work going on here, and people are looking at the future for this type of therapy, including us. So we all know that there is a target on neuroblastoma. This is a target that has been validated, I would say, because all the antibodies that are presently used or FDA and EMA approved are against this target called GD2. But making a vaccine against GD2 is very, very difficult. That's because this GD2 is what's called a glycolipid. It consists of sugar and it consists of a fat, type of fat. And our body has never been designed to make an immune response to these glycolipids. So when, for example, people started making vaccines against pneumococcus and meningococcus, they found it quite difficult because on the surface of these bugs, most of the antigens were glycolipids. So they had to take adjuvants. They had to take substances that increase the immunogenicity of vaccines or increase the chances of the body making an immune response against vaccines. For example, in order to make a good vaccine against pneumococcus, they had to add an adjuvant called aluminum hydroxide. And that's why pneumococcal vaccines and meningococcal vaccines have only come into being in the last 3 decades or so, whereas vaccines against diphtheria, tetanus, etc., have been around for much longer. So as we go along, we learn how to make vaccines against difficult antigens. So when we started going about making a neuroblastoma vaccine, we first asked the question, which antigen? And we know that GD2 and another antigen called GD3, there's a lot of it on neuroblastoma cells. So that was, choosing the antigen was relatively easy. But then these, if you just took GD2 or GD3 and injected it into patients or humans, we would get absolutely no immune response. So first we had to stabilize them. So we stabilized them by connecting the antigens to a lactone, which is a complex sugar. And the vaccine was designed and produced by Dr. Livingston and Dr. Raghupati. And this is quite an old vaccine, or the concept at least. It's been around since the 80s or late 80s. But again, even just by stabilizing the GD2 and GD3, we still couldn't make them immunogenic. So we had to add adjuvants, and the regular adjuvants really didn't work. And so they had to actually go to much stronger adjuvants. One of them is called KLH, which is actually produced from shellfish. Another was called QS21, which originally arises or is produced from a particular tree bark. And these two adjuvants were originally used in the vaccine. And then our own research involved a third adjuvant called Beta-Glucan. And I'm going to talk about that a little bit. And so this part of the vaccine was all made in the late 80s, early 90s. And then our own experiments, including my own experiments in the lab, we were looking at this agent called Beta-Glucan. And then finally, we ended up adding Beta-Glucan to this vaccine. And that's what the current vaccine against neuroblastoma consists of. In fact, we had used Beta-Glucan in combination with antibody. And we also found that this combination leads to anti-neuroblastoma effects. So how does Beta-Glucan work? On our white cells or neutrophils or macrophages, we have this receptor. It's called the CD18, CD11B receptor, and it consists of 2 sites. This one site is called the lectin site, the other site is called the I domain. That's just jargon. But what happens is that when an infection enters our bloodstream like a yeast, it has beta-glucan on the cell surface. And then that beta-glucan sticks to the lectin site. But on this yeast, because this yeast, our body doesn't want yeast inside us, antibodies against yeast deposit complement on it, and then the complement sticks to another part of the receptor. And when both these 2 sites are stimulated, the neutrophil or macrophage gets activated and starts killing the yeast. So what we thought is that if we have a tumor cell, and we know that 3F8 can easily deposit complement on it, that happened. We gave patients 3F8, but only one part of the receptor was stimulated. So we thought if we add beta-glucan, this part of the receptor can also be stimulated and lead to better cell killing. And that's indeed what we saw when we tested this hypothesis in animals and in a test tube. So therefore, our vaccine now consists of this GD2 and GD3. These are chemically conjugated to this adjuvant called KLH. And then this whole thing is mixed up with another adjuvant called OPT821. And then we give the third adjuvant, which is called beta-glucan. So that's what the vaccine consists of. And as many of you know, the vaccine is given weekly for 3 doses. Then 5 weeks later, there's a 4th dose. And then over the next 9 months, there are 3 more doses, approximately every 3 months apart. And the glucan is started after the 3rd dose. And that's the regimen. And initially, starting in 2009, I believe, we first did the phase 1 trial. Dr. Kushner was the PI or the principal investigator. And we treated 15 patients. And those 15 patients had relapse disease. After having relapse, they got some chemotherapy and they went back into remission. And this is what we call second remission. So we treated 15 patients. Some of them were in 3rd remission, or 4th remission even. They've had several relapses, but then gone back into remission. And we treated 15 patients. And even now, 10 years later, 13 of the 15 are alive and 12 of the 15 are alive without any disease. So we thought that this is quite intriguing and impressive, and we would not have predicted this. We also saw that none of these patients had any long-term side effects. So in 2012, I believe, we started increasing the number of patients. We started doing a phase 2 study, again in patients who had relapsed and then gone back into remission. And that's what I'm going to talk to you about in the next few minutes. So this first group of patients continues to do well. So in this phase 2 trial, we said, can we improve survival in patients who are in, or improve progression-free survival, that is, prevent recurrences or reduce the number of recurrences in patients who are in second remission or greater than second remission. That was the goal. The next goal was to get some more information on the toxicity, to look at the immune responses. And we basically used a similar regimen to the phase 1 trial, which I described before. And we measured antibody titers, that is endogenous antibody. And today I'm going to talk about the first 102 patients who were treated on this trial, and all of them had previous relapses. So about 2/3 of them had 1 relapse before, another 20% had 2 relapses, another about 10% had either 3 or more than 3 relapses. So this is a very high-risk group of patients who, by the textbook, the expectations would be that they would continue to relapse or even succumb to the disease. And all of these patients were stage 4. The only stage 3 patient we had was MECAN amplified. And the time from their last relapse to the vaccine was about 1 year. So basically, patients relapsed, then they got chemotherapy, they went back into remission. Sometimes it took a very long time for them to get into remission. Many of them got antibody after getting into remission, and then they got vaccine. This number actually talks about all the patients who ever received anti-GD2 antibody. But a lot of patients, we did succeed in getting a lot of patients to remission, which is another point which I have to make here, because unless we get patients to remission, the vaccine will not be effective. At least we don't think it will be effective. But by the flip side is that because our data is quite interesting or impressive, I think we have to make every effort to get patients into remission. So the first thing I want to talk about is how safe is the vaccine? And I would say it's extremely safe. We treat all our patients outpatient, and we really don't see any major side effects except for fevers, which last for less than 48 hours, and sometimes impressive redness and inflammation at the site of injection of vaccine. We've had a few patients whose liver enzymes went up, but they were very transient. They went away without any treatment being administered. And there were a couple of patients who had an allergic reaction, but none of the patients we ended up stopping antibody for, stopping vaccine for. The glucan also is quite well tolerated. One patient had hives, but the other 100 odd patients really didn't have any significant toxicities, mild nausea and mild diarrhea, which we could attribute to the glucan. So bottom line is that the vaccine toxicities were minimal, very safe. And surprisingly, patients did not get any pain and did not get any nerve damage, which also we were worried about, because if antibodies are formed against GD2, we were worried that patient would get pain, just like patients who receive antibody therapy get pain. So now in this slide, I'm showing you the survival of these patients, of 102 patients. So if you look at 5-year survival, we see that about 73% of patients are still alive at 5 years. And this flies in the face of dogma, which would say that majority of, if not all, patients who relapse are going to succumb to the disease in 5 years. So we think that this is quite an impressive record for this group of patients. However, not all, only about 33% of patients did not relapse at 5 years. So we still have a significant number of patients who relapse, but for reasons we don't quite understand, and there could be many reasons and speculation as to why, 70% of patients are still long-term survivors. Again, this rate of relapse-free survival at 5 years also way above what people would expect. And if you look at survival at, say, 2 years, it's more like almost 50%. So again, this observations made us encouraged and to continue this type of treatment. It's safe, and at least in this group of patients, it seems to improve survival. Now, if you look at those patients who had only had one prior relapse, then the overall survival and the progression-free survival is even better. So patients who had only one prior relapse, their long-term progression-free survival is above 50%. And that's also very encouraging. It tells us that if patients do relapse, every effort should be made to get them into remission and not just put them on clinical trial, on a clinical trial which may not have a good chance of getting them into remission. So this is really kind of colors our philosophy of treating patients, because we know that if we can get patients to into remission, we still have a good tool at our disposal to try to keep them in remission. And therefore, we will pursue treating patients with vaccine and continue to try to get patients into remission after relapse. The other part of it is about immune responses, right? So we know that vaccine seems to improve survival, but people, you can all say that perhaps just by getting into remission, patients are cured, although that's not what a textbook would tell you. So whenever we are dealing with a drug that we are treating patients in remission, that's no evaluable disease, we get concerned that we may not be doing anything because patients, there's no disease to follow. So one of the things that we wanted to see is we can see an immune response. If we see an immune response, a measurable immune response, we can then say with some confidence that the vaccine is working. And that's exactly what we see. So if you look at this first graph that shows that patients start making an immune response around the time of getting dose number 4. So they start off with very low titer. After the first dose, they get a little bit of antibody titer, and then that keeps on going up, and it looks like it plateaus off after dose number 6. And this this titer is quite impressive. It's not just a very mild titer, it's quite a significant titer. For example, some of our patients get as high as 1 microgram per ml of anti-GD2 antibody floating around in their blood. And to keep it in perspective, when we give a patient antibody, on the first day of antibody, they have about 2,000 nanograms or 2 micrograms. So it's only about 2 times as much, whereas this antibody titer is continuous. Now, if we measure the antibody levels in patients who are getting 3F8, say, you know that on day 2, the amount of antibody that's still circulating is somewhere here. And by 72 hours, that antibody is probably here. And then by a week or so, it's completely gone. So in the vaccine, what we're getting is antibodies that go up not to extremely high levels, but they stay at high levels for quite a long time. Whereas when patients are getting antibody treatment, those titers go up, but then they come down straight away within a few days. So one of the reasons why our patients may not be getting pain after getting a vaccine is because these low level titers, not ultra low, but lower than 3F8, maybe they don't stimulate pain. Whereas the high up and down titers of 3F8 and dinutuximab cause pain. Again, that's a speculation, but that's certainly one possible mechanism as to why vaccine does not cause pain. Now, what was even more interesting and intriguing is that patients who developed a high titer, which we defined as 150 nanograms per ml, their overall survival was very, very high. Whereas patients who got a lower titer, their overall survival still wasn't terrible, but it was lower than those who had a very high titer. So again, if survival is linked to titer, then it tells us that the vaccine seems to be working, and it's what's called a surrogate biomarker for the effectiveness of vaccine. So based on these observations of improved survival and of good immune titer, we are encouraged to continue to find ways to use this vaccine, and was the impetus for taking the vaccine onto the phase 1 trial, which is ongoing. So the conclusions so far are that despite numerous prior progressive disease, we could maintain remission after vaccine in high-risk patients. We saw that the titer was an independent prognostic marker. That is, titer and survival went hand in hand, telling us that the vaccine effect has an effect, a biological effect. And one of the other observations was that the vaccine titers started going up after using beta-glucan. So we think that beta-glucan helps the vaccine titers go up, which is why we are investigating this further. So where are we right now? In our current phase 2 trial, we have finished accruing patients. And the goal of this current phase 2 trial is whether early glucan improves immune responses. And the data is still not completely analyzed yet, and very preliminary and data which might change once we analyze the entire data set suggests that early glucan might be better. Now, how much better it is on survival, I have no idea, but the titers might be slightly better. Again, we don't know that for sure. And in this phase 2 trial, we have enrolled patients in first remission as well as in subsequent remissions. So patients are divided into 2 groups of patients. In the first group, the glucan starts after dose level 3. And the second group, the glucan starts after dose level 1, after dose 1. Again, this will take another year or so to analyze and see if early glucan impacts titers. If so, at what point does it impact titers, and whether it impacts survival. All these questions are still unanswered. So where are we today? The phase 2 trial, this current phase 2 trial has been completed. More than 150 patients have been treated, but we are being allowed accrual to continue accruing on this trial until the next trial opens. And I'm going to talk about that a little bit. We also know that we did not see any further toxicity. We also saw that anti-GD2 titers, we continued to see good anti-GD2 titers, suggesting that that's not just a fluke. And we are now also looking at changes in the bacteria in the gut to see if they have any impact on titers and on survival. So how do we fit an antibody currently into our treatment for neuroblastoma? In patients who have high-risk neuroblastoma, they undergo surgery and chemotherapy. If they are in remission, as many of you know, we don't do transplant. Patient goes straight into antibody therapy and remission, antibody therapy and radiation. They do 5 cycles of that. If they continue to be in remission, they are offered enrollment onto the vaccine trial. Patients who don't go into remission get some other type of therapy. And if they go into remission, they get treatment with antibody and GM-CSF. If they continue to be in remission after 5 more cycles, they get vaccine. So this is a trial, but we have now incorporated into our first remission patients, although the primary question that we're asking is whether early versus late glucan titers matter. So that's the current status of the phase 2 trial, and I'll be happy to answer questions at the end about that. Now, where are we going from here? One question is, can we improve or enhance the anti-GD2 titers? If titers really matter, can we go up? Can we make better titers? So should we consider other adjuvants? And one of the adjuvants you're considering is GM-CSF. Another question is, what happens to those patients whose anti-GD2 titers fall over time? Say they get titers present at 1 year, but then at 2 years and 3 years, it starts falling. And are those patients relapsing at higher numbers? Again, we don't know the data on that yet. It's possible that falling titers might be associated with higher risk of relapse, but we don't know that for sure. Should we be giving these patients boosts? And indeed, in the ongoing trial, that's one of the questions we are planning to ask. And then again, beta-glucan, what's the role of beta-glucan? We invest a lot of effort, money, etc., in trying to get beta-glucan, but we don't know for 100% whether it's working. We feel strongly that it's working, but that question might be answered in the current trial where early glucan is being given. If indeed early glucan shows some advantage for titers or survival, then we know that that's an important part of the vaccine. Then the question is, are we choosing the right patients? Are patients in first remission benefiting from vaccine? And that's indeed a very controversial area, I would say, because as many of you have heard, after patients finish antibody therapy, both at Memorial and all over the world, a patient who's gone through chemotherapy, surgery, transplant, remission, and antibody, and goes into remission and is on antibody and receives antibody and continues to be in remission, most people would say that the odds of being cured is at least 70%. So should we be treating these patients with vaccine? In order to show that vaccine makes a difference in this group, we'll have to do a randomized trial, that is, treat half the patients with vaccine and the other half with no vaccine. And in order to do that, we need a lot of patients, probably needs to be done internationally, and we'll also need backing from pharma. What about for second remission patients? if a patient in second remission, are our data valid? We show that patients who relapse and then go back into remission, half of those patients in second remission are long-term survivors at 5 years at least. So maybe is this just peculiar to a single site, or whether it's can be observed by all centers? And again, this is also very important. I think a multi-center study really needs to be done for this group of patients as well. And again, that will also likely need pharma involvement. And then lastly, but something close to my heart is, if the vaccine is really effective, we know that doing antibody therapy is very difficult in patients from the developing world. It needs a lot of resources and so on. But if vaccine really elicits titers and is effective, this should be made available to children around the world. I'd like to thank a lot of people who, it's a small snapshot of folks from our group, but this is a huge effort and a lot of, it's a big team, and I'm fortunate to be part of it. And if there's any questions, I'll be happy to take those.
That was great. Thank you, Dr. Modak, for walking through all that. Lots of information, but lots of questions. So 17 questions, some of them longer than others. So, all right, let's just get through them. The first one is, can you say anything about the new trial that's going to open shortly at MSKK? Obviously, you talked a little bit about it. Can you say anything about timing?
Yeah, so in terms of study design, it's I don't see, I think those questions, we have come to a consensus about study design, which is going to be investigating the role of GM-CSF, also randomizing patients to getting GM-CSF versus no GM-CSF, and also continuing vaccine in the second year. Now, the design maybe is one thing, but in implementing it might not be that straightforward, primarily because we will need some sort of pharma support to make glucan, as well as make the vaccine available, as well as getting GM-CSF off label. Now, these questions are we're still working quite hard on them. And I don't really have a clear-cut answer as to when this trial will open. When we first thought earlier this year, anticipated it would be open early next year, but I'm pretty sure that's not going to happen because of all the things I mentioned, not because of issues with the design, but getting all the components of the vaccine. And I really can't say much more about that because there's a lot going on in terms of availability of all of these things, and it's really up in flux. It's a moving target today.
Okay, yeah, I think that's a good answer. All right, there seemed to be some skepticism regarding the vaccine study at COG and SIPEN groups, as the trial is not randomized. Are there plans to do a randomized placebo-controlled vaccine trial? Or do you believe there's sufficient evidence to prove efficacy by continuing with the current single-arm trial design?
Yeah, so this is a very good question. We have been in, and over the last year, we have been in contact with COG and SIPEN. At least with COG, we are in regular contact with the vaccine. The question is not that straightforward at either of these two centers. The skepticism, I think, is partly justified, but both of these two groups would like to do a vaccine trial, I think, based on our discussions. And I think where to do the vaccine trial under the supervision of COG and SIPEN is a question, because COG currently is conducting a trial where they have a fixed way of treating patients with MIBG therapy, etc., and those patients will not be eligible to get enter another trial at the end. So that's a question that COG has to answer for themselves as to when. I think it'd be easier for an international trial in patients in second remission rather than first remission. And whether those patients should be randomized or not is up to the COG and SIOPEN as they look through the landscape of neuroblastoma. Our interest in vaccine as of now is mostly to figure out the best composition of the vaccine, that is, which of the adjuvants should be used, so that once we figure that out, we can present it to COG or to other consortia to run a randomized trial. We as a single agent, we cannot run a randomized trial. We don't have enough patients. I think for first remission patients, if you were to do a randomized trial, there would be at least 300 patients required in each arm. And we definitely don't have those numbers of patients or even the resources to conduct that sort of randomized trial. Now in second remission, if you look at the published data, the outcomes for patients in second remission are pretty, they're not that great. So to do a randomized trial would also need some buy-in from COG and parents, and whether a randomized trial can be done in that population. But as I said, at MSK, our goal is to figure out what's the best vaccine to take forward. And to do a randomized trial, we'll have to do it in multiple centers, and we are completely willing to do that.
All right, great, thank you. The next one, the vaccine trial results from the maintenance trial for patients in first remission. I think you touched on this in your presentation, but when do you think you might have those results?
Again, for the first remission patients, the question that we are asking is about glucan, right? Early versus late glucan. And that trial will be completed. But because first remission patients are not being randomized, I don't know what we can make of the information for that group of patients, because the study design wasn't asking the question whether that first remission patients' outcomes are improved. The study design will only tell you about the glucan, early versus late glucan. So we could look at the data and see what it all means, but even patients in first remission on that group have all had a lot of different types of treatment coming into prior to achieving first remission. So it might be a very difficult group to analyze. And again, for first remission patients, I would not accept any data, good or bad, as proof that the vaccine works or doesn't, because that requires a randomized trial.
Okay. All right. I'm getting a question actually here, a note here, if you could stop sharing your screen so that people can see your image a little better, if you can do that.
Sorry, yeah, let me.
That's no problem.
Yeah.
The next one is a question. It's kind of long and written. It sounds like it's talking about families, international families who are coming to access a vaccine trial, and obviously cost them a lot of money to be able to get to New York for that treatment. I think the question is here about whether there's an option to have some of the treatment itself, the cost of the treatment itself. It doesn't sound like they're talking about travel, but the treatment itself covered as part of the trial design, with the trial sponsor actually covering that, since there isn't, really for first remission kids, and particularly there isn't really the evidence yet there whether it makes a difference.
Yeah, I mean, this is something I really feel not that great about, because we have quite a few patients coming from abroad, and I can see all the stress they're going through and all the moving heaven and earth to come. And I feel, are we doing the right thing by keeping the trial open, right? But also the flip side is that none of these trials are associated with any pharma support, right? So even to make the vaccine, we've got to fundraise, and that's millions of dollars of fundraising. The cost of the vaccine is not, patients don't get charged for the cost of the vaccine, but because the memorial system, I mean, the American system of healthcare is extremely expensive, wasteful, and so on, the clinic visits are charged to the patient.
Right.
But the vaccine itself and the glucan, we still have to raise more than $1 million to do even one study. So the flip side is what goes on behind the scenes without pharma support to run a clinical trial is not, I don't think patients should think about it, but it's a lot of effort and work and so on just to raise funds for it. And so I think, I don't have an easy answer for that. And again, this is something there might be some of my patients on the phone, but whenever, or on the Zoom call, but whenever for a patient, international patients comes to me, I always ask them to consider whether it's worth it.
Right.
Because it may not be worth it for first remission patients. So on the other hand, we do want to know what all these biological agents are doing, and if this is doing something, we want to know what's the best combination. So it's that balance. I don't know how to achieve it better. I would also say that we have completely open to sharing the vaccine with anyone else who can start a clinical trial, but each component of the vaccine is controlled by different entities, which I don't want to go into right now, and that has made things harder.
Okay.
Memorial doesn't own the vaccine, for example.
Right. Okay. Great, thank you. I'll just keep going through the list here. We do have quite a lot left, but I've been told that we can go a little over because there is a break after the session, so we have a little more time. Okay. So Dr. Modak, do you have data on children who repeated vaccine after relapsing the first time around? Do you see any benefit in continuing to do the vaccine until the child produces titers?
Yeah, this is a good question. I think we don't, what happened was that we only started collecting blood from patients after the 1 year later on. So we don't have that many blood samples from patients beyond 1 year. So I can't tell you with a lot of confidence that the titers beyond 1 year matter. And that's a question that we're asking in the new phase 2 trial, whether we should be giving vaccine beyond the first year. But I don't think the current data set will give us complete confidence as to what happens beyond the first year. And I know Vicky's asking me about, is there a difference to the timing or level of titers in the first? I think this question is about first versus second CR. I think it's really the disease rather than the patient that's dictating it. Once a patient relapses, that disease becomes much more resistant to everything we throw at it. So I doubt the titers will matter, but we'll be able to answer that question in about 6 months from now, I think.
Okay. Dr. Modak, if there are sadly patients who relapse while receiving the vaccine, is it always the case that those patients would need to restart the vaccine from the beginning again once they're back in remission?
The current protocol allows us to, if patients only need radiation or surgery to take care of the relapse, they can go back onto the vaccine. But if they need chemotherapy, then unfortunately they've got to restart the vaccine. And whether that's good or bad also, I don't know. We've had several patients who did not have titers the first time around, but had titers the second time around. Again, the new trial is likely to extend that to 2 years, and then that might be of benefit.
Right. All right. Is there any news on when the vaccine trial for kids?
Yeah, unfortunately, as I said in the beginning, I don't know the answer to that.
You don't have,
too many things. The protocol is written and it's out of our hands.
Yeah, you wish you could start it.
Yeah, we wish we could start it, but real life is different, I think.
It's complicated, yeah. All right, can you comment on the M positive patients who went on the vaccine? Since they seem to relapse earlier, is it possible there's a difference between these groups?
Yeah, I think the vaccine, for MYC amplified patients, it's not only the vaccine that's important. I don't know whether vaccine does anything or not, but MYC amplified patients, in my experience, either relapse early on or they never relapse. So as I showed you in my slide, we did not have that many MYC amplified patients in the second remission group. That's because patients with MYC amplified disease in the modern era, I suspect they have at least no worse prognosis. Possibly might be even a better prognosis because they respond so well to chemotherapy. So either they relapse or they don't relapse. And patients who, in the second remission group of patients, we see, we had 80% non-MYC amplified or even higher. That's because most MYC amplified patients, if they relapse, they almost never get into second remission, unfortunately.
Okay. Next one, is there any reason?
That's a very good question, whether this vaccine should actually be therapeutic for measurable disease.
Right, exactly.
All vaccine trials thus far in the whole world have not been effective in patients with bulky disease. And even with 3F8, we don't see responses. Only now we've started seeing responses in patients with bulky disease. But in both the COG and us, for soft tissue disease, we all add chemotherapy to 3F8. So these vaccine titers for soft tissue disease are not likely to be effective based on experience with antibody therapy. However, for bony disease, they might be effective. We haven't had the guts to test it in that setting, mostly because we have other options for patients who have recurrent bony disease. For example, chemoimmunotherapy response rates are more than 40%. But that's certainly a question we've asked ourselves a lot. And I think eventually you're going to ask that and look at this group of patients.
Okay. Yeah. What percentage of kids are only making low titers by the end of the trial? And is this percentage similar to kids who don't make titers to childhood vaccines, for example?
That's also, I don't know the answer to that because we didn't have the wherewithal to measure titers against childhood vaccines. That was not part of the trial. We do measure vaccines, titers to childhood vaccines sporadically, but we don't do it regularly. And that's something we should. Many vaccines actually use diphtheria. Some cancer vaccines have started using diphtheria vaccine as part of the cancer vaccine. And that's because these might be going hand in hand. So I think we've got to definitely look at it. And one easy way is to look at the flu titers because flu is so prevalent and everybody gets the flu vaccine. And we have been starting to measure that. Patients who get the vaccine also getting the flu vaccine and do the mount titers against flu as well as, but we don't have the answer to that.
So you haven't looked at like the big picture, like what percent as a percentage of the trial it does.
We don't have this data because we never measured.
Right, but even just, okay, yeah, all right, I see what you're saying. Can you please comment on censored data on the progression-free and overall survival slides, explain the overlapping confidence intervals for the curves, and what are your expectations on how the results will look when later analysis is complete?
I didn't think that those curves on the OS were overlapping a whole lot. I think we are quite confident that the overall survival seems to be better in those who have high titers for sure. This trial is actually over. This trial, which I showed you, is complete, accrual is complete, and the curves you saw are almost similar, almost identical to the ones that will be published in the paper, and the questioner can also look at that paper when it's going to come out in a couple of weeks, I expect, and then I'm happy to get an email if there are follow-up questions after that.
Okay. I feel like maybe you've answered this one, but children that are in remission have had the vaccine, what percentage are still in remission? Doesn't say.
In second remission, I showed you that
Right.
30% are in remission at 5 years, or 33%
Right,
in remission at 5
Okay.
years. First remission, I don't have the data yet.
Right. Okay. What are the reasons why kids are not making titers despite several vaccine doses, and what can be done to improve the results?
Yeah, that's exactly the question we're answering. Should we use glucan early? Should we add GM-CSF? Should we give more vaccines? So those are the questions that we're asking.
Okay. Is there any data on how many relapse patients successfully get back into remission? I.e., do 30% of relapse patients get back in remission more or less?
Every relapse patient is different. I would say my experience in the modern era is that more than close to 50% of our patients might be getting back into remission, but that group is very heterogeneous. I'm talking about first relapse. I would say at least half of our patients, if not more, in first relapse will get back into remission. And in the modern era, we are seeing far fewer relapses that are explosive. Most relapses occur in a single site, and we can get on top of that. That's why the push towards getting those patients into remission, because now we have options for those patients, antibody plus vaccine or vaccine alone. So that's something I'm quite keen about, that we should all make an effort to get patients into remission.
Okay. Last three. What are the results with children that have relapsed multiple times? 4 times is in the question. Is there improved survival in those children?
That's not peculiar to vaccine. I would say that in general, I think more and more patients are surviving longer and longer. Mm-hmm. And because, as I said, relapses are often manageable. Sometimes relapses are single bony sites that can, even if they don't respond to chemotherapy, might respond to radiation. And that's why I think there's no blanket answer to a question whether any child who relapses should not be treated, because it all depends on the type of relapse and so on. So right. I would say that overall survival has really improved, not only with us, but other centers around the world. And that's because better chemotherapy and better antibody and safer radiation.
All right, thank goodness for that. Can you talk to any international collaborations to answer the planned questions you have for the future challenges?
So, I mean, if you really go granular, in a granular way, we need pharma support for vaccine, we need pharma support for glucan, and we need pharma and international buy-in to decide what is the best type of trial to run, whether it should be randomized or not randomized. So these are the open questions, and we're working on all of this. But as of now, we don't have the answers to that. And I'm open to, any questions that or ideas about how this could be achieved.
Okay. What percentage of children, with multiple relapses prior to starting vaccine relapse while on vaccine? What percentage relapse within a year of vaccine?
I would say quite a high percentage. Again, I don't know. I'll have to go back to my curve and see. I think for second remission patients, that is not multiply relapse patients, I think there was 30% of patients relapsed within the first year. But for multiply relapse patients, that number is higher.
Okay.
Yes, we are thinking about giving a boost.
Yeah. Yep. So this question is saying, would you even do it like 5 years later? Or, I mean, right now, I think you're only talking about the 2 years.
We're thinking of. The new trial will likely have one boost a year every year.
Okay. All right. And last one, Dr. Modak, in relation to mild residual disease, can children be enrolled with one hotspot?
Depends on what hotspot that is and if it is PET positive or PET negative. But I can, if that question is about a specific scenario, I'm happy to take it by email.
That sounds great. Gosh, we got through them. That was amazing. Well, thank you so much for all this information. Both.
Thank you for everyone who attended. And Helen, I thank you.
Yes, you're welcome.
SPC group, they really doing a lot for kids around the world, and I hope we can keep going.
Yes, thank you so much for your time today. And we have to finish up this session, but it looks like there is one more left, the general Q&A panel session. So if any of you want to watch that, you can head over to the Watch Live page. Thank you, and
Thank
have
you.
a great day.
Bye-bye.
Bye-bye.